guys, welcome back, and today we are going to talk about one of the probably coolest drugs ever. If you've ever had it, it's an incredible drug. The bad thing is you don't remember it. It's the old milk of amnesia, and of course this is Propofol. Now there's a reason I kind of put the little stay in there. Michael Jackson sang from 5 to 50. That's kind of an important one that we'll talk about a little bit later when we get to dosing. So, but remember that, and Michael kind of made it famous because his doctor was giving him this drug in order for him to get some sleep. Problem was he overdosed him on it, and because of that he quit breathing altogether and ended up dying because of it. So again, this drug has some serious things. Now we usually don't use it frontline EMS, but the problem is we're going to go pick up patients that have this, or we're going to have patients that had this administered to them, and we've got to know how to figure out how to fix them. It's also known as Diprovan, and if you look at this material, it's kind of a milky white because it's a lipid-based drug. Now, the cool thing about the lipid-based drug part of it is it easily crosses the blood-brain barrier, and of course it works wonderfully. However, the problem is there's some precautions that we got to take with the drug when it's being used. Okay, so it's a sedative hypnotic agent. Again, it's used for it maintains sedation, and it is very good. When other drugs don't work, Propofol usually works pretty good, but again, it can build up a tolerance. So, as Michael found out, again, they kept using it. They gave him an extremely high dose, and of course, they didn't have the reversal agent. So it's a short-acting sedative hypnotic. It produces anesthesia and very deep sedation, okay? The exact mechanisms aren't exactly known. However, it's known to slow down the limbic system's impulses, okay? So, again, it just basically shuts everything down. The good news is once you give this, 15 to 30 seconds, matter of fact, when you give it, they'll watch it go into the IV site. And the second that they go into the IV site, they're like, oh, okay. And next thing you know, you're out. Okay. The last time I actually had it, I tried to stay awake intentionally. Nope, it didn't happen. And the good thing about Diprovan is that it wears off in about 5 to 10 minutes. It's very quick. And once it wears off, it's done. You don't have those long-term effects from it. So knowing that, you got to understand that keeping that particular drip going is of paramount importance. It again maintains, it's to induce and maintain the anesthesia and conscious sedation. And when you use it when patient needs sedation for a very painful procedure, intubations, and it must be given via continuous IV infusion. Okay. Now in anesthesia, guys, they'll do what's called a push presser. So they'll actually push it a little bit in order to deep sedation. You'll see this a lot at the gastrointestinal when they go in to do the colonoscopies. They'll give you a push dose instead of a drip version. But they sit there and continually do that and monitor you while they do that. Usually a nurse anesthetist does that. Again, it's obviously it's going to do all the wonderful things that a normal sedative will do. So again, but it can cause seizures. It can cause a headache afterwards. Changes in mood swings, it can also do that. But again, this drug wears off pretty quick. Again, it can cause some tachycardia, bradycardia. It can kind of go either way. And it actually, in kids, it actually makes the blood pressure go up, which is kind of a concern. Most of the time, though, it's going to drop a pressure. Because, again, it relaxes everything. And again, it's going to cause respiratory depression and knock out respiratory drives. These actually are kind of really low side effects to this. Matter of fact, that's kind of why they like to use it, because they don't get nausea or vomiting near as bad. You can get a little bit of pain at the IV site. Remember, this is a lipid-based drug, and as such, you can develop gallbladder problems actually if you use it for a very long period of time. Okay. So when do we not use this? If they've got an increased intracranial pressure, this is a no-no. If we have impaired cerebral circulation, this is a no-no. The soybean, egg, lecithin, and glycerols are all fat-based. And so if they're allergic to that, they're probably going to be allergic to the Propofol. Okay? If they're doing obstetrical procedures, we don't want to use Propofol. It does cross the the placental barrier. And again, it can have some pretty nasty side effects to the fetus. It can cause epilepsy that has been known to cause seizures, so kind of watch it with, if they got liver or kidney disease, you're probably going to have to use a reduced dose on those folks, because again, instead of 5 to 10 minutes, it usually lasts a little bit longer than it does. It doesn't metabolize in those two areas. It's not excreted as easily. Again, watch out with your benzos or other sedatives, because that could increase your side effects. And again, it's when you stack pain relievers and narcotics and benzodiazepines together, of course, you get a potentiated effect. So you don't want to do that. It is a lipid-based drug, and as a lipid-based drug, you absolutely have to maintain a septic technique. Okay, you absolutely have to do that. We don't want germs. Germs can easily grow on this stuff. Okay, so again, you've got to maintain it. It's an emulsion solution. It's a fat-based solution. It will grow germs like crazy. This person probably already has enough problems. Okay. Elderly folks, debilitated neurosurgical patients usually reduce their doses, and you're going to reduce the dose also if the patient's already received a lot of narcotics. Okay, again, that potentiation effect. If you are giving Diprovan, it needs to be via IV pump. Period. Next question. No more in 24 hours, because again, it can send the lipid levels up to way too high. And you don't want to bolus the patient due to marked hypotension. And the patient must be intubated during use, especially in the pre-hospital setting. You really don't want to not have them intubated. That's kind of a good thing. And use analgesics as well. Just remember, you can back off of them where maybe 50 mics of fentanyl would have worked earlier. Maybe 10 mics of fentanyl actually will probably do pretty good. Again, usually it's the one that I've always seen is 500 milligrams of 50 mLs. That's the one that I've always seen. But you can have bigger bags depending on where it is. You might see in the ICUs they have the bigger. They might even have those bigger bags. For anesthesia, usually 2 to 5 milligrams per kilogram over 1 minute, and then they maintain it at 100 to 200 mics per kilogram per minute. For sedation, it's the 100 to 150 mics per kilo per minute, and then you follow it by maintenance infusion. So you're going to give these folks a loading dose. All right, that is a normal thing that we do. But when we use it, it's usually because they're already intubated and we're transferring from one place to another. Okay, and again, it's usually the maintenance infusion is 5 to 50 mics per kilogram per minute. All right, so that's what our normal is. All right, so that's the thing I want you to remember. Michael Jackson sang from 5 to 50. Okay, so when we're using it for transfers or we're using it for any purpose, usually in EMS, somewhere around the 5 to 50 is where we're going to do it. And I can probably tell you guys, 5 is probably going to be your sweet spot number, actually. Very rarely do you have to take it up higher, 5 to 10. But we titrate this to effect, okay? So if we start them at 5 and they're still kind of moving around, turn it up. Keep turning it up until they're not moving anymore. And again, hopefully you've got them intubated, and we can, at that point, that's the only time that I think you should be using this drug, is once the patient is intubated, okay? And the maximum dose is 150 mics per kilogram per minute. Some people, though, do require higher doses, especially if they are used to Propofol, which kind of sounds weird. Newborns, infants, and children less than 3 years of age, we just don't use it. It's usually a lesser dose, 1 to 2.5 mics per kilogram over IV over 1 to 2 minutes than the maintenance drip. That we actually have to elevate because it takes a little bit more to maintain the sedation on these kids. All right, again, we can give this IV drip, and they say that you can use it in pregnancy, but it crosses the barrier. I'm kind of surprised about the category B here. I would use it in very much a caution in these patients, okay? They say that there's no adverse effects on the fetus, but I would, again, very careful with the pregnant patients with this one. All right, so that's the Michael Jackson drug, the Propofol. It's again, if you are truly doing a transfer and they're offering to send them with Propofol, don't be afraid of it. Remember, keep it clean, keep it septic, and titrate it to effect, somewhere between 5 to 50 mics per kilo per minute. That's where you want to be. All right, I'll see you guys on the next one.